Okay, we seem to have a small pause in the admitting people from the lobby, so look, we might start in the interest of making this a timely session. For those of you who don't know me, my name is Sally Redman and I'm the CEO of the Sax Institute, and I'm so pleased to welcome everybody to this session today. I know it's going to be a really interesting and exciting session. I've been really looking forward to it, and want to thank all of the speakers for making time and preparing to share their thoughts with us. I'm sure it's going to be fascinating. So I'd like to start by acknowledging the Gadigal people of the Eora Nation. These are the lands on which I'm meeting today, and I'd like to pay my respects to elders past and present and emerging, and particularly extend that respect to Aboriginal and Torres Strait Islander people who are with us and joining this session today. I know everybody is on the lands of different Indigenous people, and you might want to pay your respects to those traditional owners as well. So look, this symposium is part of a stream that we're planning through the work of the Sax Institute. It's the first of these, so we very much welcome feedback on how they run and suggestions for the future. We particularly want to thank the Ministry of Health and welcome the people who are here from the Ministry, as the session has been organised and with them. And I think I also wanted to acknowledge the participants from NH and MSC. We're pleased to have you online today as well. Thanks everybody for coming. And Amanda, I might just get you to move the slide on. So I just wanted to give a very quick introduction and just say really that this is such a good time to be having this session, because we've been on something of a journey, I think, as we talk about evaluation, and I think that's going to be unpacked in the presentations today. I think, you know, if we went back 20 or 30 years, you know, it was all about how can we take the methodology of randomised trials and somehow superimpose it on the way that we think about the evaluation of policies and programs. Today, I think we all recognise that it's much more complicated than that, and there's a lot of nuanced thinking about when evaluation works, how to do it most effectively so that it informs the way that policies and programs and services are implemented in practice in the real world. And I think there'll be some really great insights about that today. So next slide, thanks. So the objectives of today are really to think about the challenges, approaches, and methodologies around the evaluation of health policies, programs, and services. So, and then I think what we want to do also is to think about opportunities for the future. Where do we see this field heading? And perhaps other things that we might do at the Sax Institute or through the Sax Forum to help us you know, strengthen our work in this space. So I'll leave that for the discussion as we move forward. Next slide, thanks, Amanda. So the program looks like this. So essentially, in a moment or two, we'll be hearing from Nick Mays, and then we'll have 3 case studies, one from Liz Hay, one from Anne Redman, who we're not related, I should say, from Luke Wolfenden, and then we'll have about an hour for discussion and questions, and I'm sure we'll use all of that time. Next slide, thanks, Amanda. In terms of housekeeping, I think everybody has their video and microphone sort of muted centrally. When we come to asking questions, be really pleased if you could use the chat function, so Teams chat function, and we'll try and pick those up and address them to people on the panel. We'll also try to turn your video on and unmute you so you can ask the question directly. But because we've got a large number of people registered for the session today, that may not work as efficiently as we would like it to. So bear with us. And I should also just let you know that the symposium is being recorded. So if you have colleagues who would have liked to have been here but can't attend this morning, then that will be up on our website shortly. So I think that's perhaps all I need to say by way of introduction. I see some people are still coming in. I'm not sure quite what the Zoom thing is. Trickling in the doors would have been the old-fashioned way of saying it, but welcome to everybody who is here already. So our first speaker this morning is Nick Mays. So Nick Mays is somebody, I've known Nick for such a long time, and I guess he has really pioneered work in this area. First, when I first met him, he was doing 3 months a year in Treasury in New Zealand, and so really an interesting example of somebody who has always worked in that space between research and policy. He's Professor of Health Policy in the Department of Health Service Research and Policy at the London School of Hygiene and Tropical Medicine, and he directs the NIHR-funded Policy Innovation and Evaluation Research Unit, Peru, which really has focused very much on thinking in the space that we're talking about this morning. So we've circulated detailed bios of everybody, I think, with the materials. So Nick, welcome. I'm so looking forward to hearing this presentation, and over to you, I think.
Thank you very much. I'm going to try and share my slides, and thanks for the welcome. Is this working? Let's see. Yeah, it's working.
Great.
Are you able to see what I'm seeing? Full screen
Yes.
Slides.
Yes.
Great. What I'm going to do is I'm going to reflect on my own experience, but also of a very particular way of relating research, evaluation and policy, which is the English policy research program, and particularly the way it relates to what we call policy research units, one of which I direct. I'm not advocating this particular model. I'm just really outlining the way it works. It's a very long enduring model, so it must have something going for it. But and also try and explain where it sits in the kind of spectrum of different ways of relating policy evaluation and policy making. And I'm really talking from an experience of what would be the equivalent, I suppose, of New South Wales government and its relationship with academia. So what in England would be sort of national level policy making. The policy research programme has been in existence since the late 1960s, and its remit hasn't changed a great deal. It's to support the Secretary of State for Health, i.e. the Minister and senior officials in the department, and now with an extensive range of arm's length bodies, with research, analysis, evaluation, and so on. It's only recently become part of the National Institute for Health Research, and it remains very strongly shaped by the needs and perspectives of our Department of Health and its related arm's length bodies such as NHS England. If you want to learn more about the PRP, those are some links. And what's interesting about the policy research programme is that it funds a variety of different kinds of forms of policy related research. So very conventional individual competitively tendered research, programmes of related studies, but also what I'm particularly going to talk about this morning is the policy research units. There are currently 15. They're largely academically led. They're collaborations across universities in the main. They're relatively long-term funding. They're competitively tendered every 5 years. Because of the kind of work they do, they're usually highly experienced teams, or at least led by highly experienced researchers who can sort of understand this particular context of working quite closely alongside central government departments. And they undertake a mix of short and long-term responsive and also proposed projects. So they have work programs which they pitch to the Department of Health and the ALBs, but they also have to maintain a certain amount of responsive capacity. PRP also funds some systematic review facilities and an analytical facility which specialises in very, very rapid responsive work, mostly using existing routine and administrative data. My unit is one of those policy research units. We've been going about 10 years. This is our current remit. So we are perhaps the most generic or wide-ranging of the units. And you'll see that our remit is to evaluate or do research on policy ideas and initiatives that are being piloted or tested, perhaps at a relatively early stage, or at least they're relatively novel, maybe to the English context. And we do this by supporting or undertaking evaluations. So we might advise on evaluations that other people are going to do. We might also advise as to whether evaluation is feasible, necessary, has already been done somewhere else, for prototypes, demonstration schemes, and a variety of other things. We do a bit of methodological research, and we tend to try and situate our analyses within the wider delivery system that they sit within, rather than looking at discrete interventions in isolation. So we're not a topic or specialty specific PRUs. There are PRUs on children's services, on maternity, on older people, and in mental health. So we're somewhat unusual in having this generic function, and we are probably the most responsive of the PRUs. And I just wanted to sort of characterize the way that PRUs work, or indeed the wider policy research program. It doesn't correspond to any of the four models on this slide. So we are definitely not a co-production kind of set of organizations. In fact, we could argue we're sort of at the other end of a continuum. So it's a system that's trying to make policy research and policy evaluation highly relevant, timely, accessible, and used, but it doesn't use either co-production or embedding or actually formal knowledge brokering, and nor do we have any boundary organizations. So essentially, the rudiments and fundamentals of this haven't really changed for a very long time, which either says something about the conservatism of the Department of Health, or that somehow this fits their policy making approach. It's quite a conventional sort of purchase provider, commissioner provider model. It relies on very strong intermediation by liaison officers who are civil servants. They're research managers within the department. They're not knowledge brokers. They do not sit in an intermediary organization. And the best way I can describe the way we work is as researchers on the outside, we maintain what has been described really as close distance by Van Egmond and colleagues. So we're a long way from co-production, but and so we don't work in policy making. We don't do policy work. We have a very strong emphasis on public and patient participation and engagement, at least in theory, particularly at the front end of projects. The civil servants tend to forget about some of that as we get into the detail of projects. And the question really that I'm trying to sort of shed some light on this morning is, what's the value of this close distance model between policymakers and researchers? It essentially maintains a very distinct role and separation between researchers and policy officials, and it's obviously been extremely durable. In some ways, it's rather old-fashioned. It's seen, I think, as protecting the credibility of research and evaluation, and that's something maybe we can come back to talking about in the discussion. So if I was to draw it diagrammatically, I think this is the way I describe it. So I've deliberately drawn the Department of Health slightly above the external researchers. There is a power asymmetry there because they've got the money that we depend on. The liaison officers I've deliberately drawn, they're inside the bureaucracy. They are not in intermediary roles. They're not nested within the policy research units. But what you've got in the middle is a really quite solid and strong and continuous interaction and negotiation around about the nature of the research question, the approach that's going to be taken. But largely, the actual doing of the research is very much undertaken within the PRUs. We do not engage, for example, any of the officials in the department or the arm's length bodies in our research teams. So the model is very much of external research. So the implication for us as academics is that we rely extremely heavily on the organizational knowledge and credibility of the liaison officers in the Science, Research and Evidence Directorate in the Department of Health. They're critically our eyes and ears. If they don't understand what's going on in the department, then we really struggle. We need close working relationships with officials but were rarely, if ever, directly involved in policy development. In fact, the NIHR would regard that as a conflict of interest. This model very much requires researchers with a willingness and ability to engage rapidly and to be willing to negotiate the research questions, the scope, the timing of work. So willing to spend quite a lot of time and energy talking to civil servants about, and policy teams about their issues and what they want to learn about. So why is this model persisted? You know, what's in it for the Department of Health and their arm's length bodies? Well, I think there's sort of symbolic and instrumental values associated with this approach. On the symbolic side, it contributes to the ability of the bureaucracy to be able to demonstrate or say that they're following the science. So this kind of gives them the credibility of being evidence informed. More instrumentally, it, for example, allows the Department of Health and government sometimes to distance itself from the findings and to disown uncomfortable findings, or to emphasize, on the other hand, the objectivity and credibility and the unbiased nature of the research. So they make a big emphasis on peer review, on independence, on the fact that these are not civil servants doing this analysis and so on, particularly when they're under criticism. But sometimes they will definitely distance themselves and say, well, that's Professor Mays's team's view, and that's all very well, but actually there are other perspectives are available. It also gives them ability to have access to a group of researchers who've got long experience and are familiar with the way that government does its business. So sort of quasi-insider status. And I mentioned the fact that these units tend to be led by people with a long experience of working alongside the policy community. Managing this close distance relationship is a bit of a paradox, really, because it is both arm's length and quite close in. To make it work, in my experience, your researchers need good political awareness, because sometimes even innocuous issues can contextually suddenly become very sensitive at a political level in a way that can take less experienced researchers by surprise. You need to be able to spend significant time in that liaison work and working alongside the liaison officers. You have to be willing to decide to occupy a relatively highly trusted insider role. But the downside of that is occasionally you can be heavily criticised by your academic peers, or as George Davies Smith and colleagues commented rather sardonically a few years back, that you can certainly be accused of producing policy-based evidence. In other words, evidence where, in a sense, the foundations or the actual focus of the research is driven by policymakers rather than by the research community. And I think it's best led by highly experienced researchers with relatively secure positions in universities, so that you can take on issues that might not work very well. You can speak truth to power and so on. Sally asked us to talk a little bit about some of the tensions in this relationship. I've already touched on a number already. The first one she raised was, rigor versus pragmatic needs of policymakers. My view about this is that it's probably less of a trade-off than a lot of people might expect. If you recruit the right kind of staff and you set their terms of reference, then I think it is possible to have a kind of both-and culture. You both meet the needs of the academic community with peer-reviewed output, and you can meet the needs of policymakers with a whole variety of different forms of communication. Pragmatism may dictate the speed of a response, the duration of the work, the scope, but it need not necessarily harm the rigor, particularly if you relate the scope to the time available. And in our experience, for example, getting involved in early, responsive, quite formative work can often lead to longer term, more summative types of evaluation, which have perhaps more opportunity for methodological and other development. And of course, good summative work requires thorough understanding of the nature of the policy intervention that you're trying to understand the outcomes of. So in a sense, it's a necessary stepping stone to that. Sally also sort of asked us to think about what do we mean by independence in this context. I think the independence is actually quite attractive to most university-based researchers, but of course it's a relative, not an absolute. And inevitably we're quite dependent on the funder, And so you have to decide, how far are you prepared to go along with the imperatives and priorities of the day, or do you wish to pursue your own research independently of government or seek alternative sources of funding? That independence comes also with the way in which you're essentially excluded from direct involvement in policy development, either before or after an evaluation has taken place. And I mentioned the NIHR having a view that too much involvement in actually moving forward a policy somehow compromises your independence and objectivity. I think this kind of keeping the researchers at arm's length from actually being involved in providing direct advice on policy making also fits very well with the British sort of central government policy making style, which tends to be rather secretive. One of the downsides of this is it's quite difficult to know how the findings of your work have been used. And with that, I will stop. And if anyone is curious about either PIRA or the policy research programme, I'll leave you with our contact details, and I included some web links earlier on. Over to you, Sally.
Thanks very much. Really, yeah, it's a very interesting model, PIRA, and interesting to hear about its length of its duration as well. That's really remarkable. I particularly liked the concept of an arm's length body. It's kind of it's a sort of interesting sort of concept. So look,
yeah, the close distance thing is worth pondering, I think.
Yes, it is, and it's a interesting. There was much in what you said that's very much worth picking up in the discussion. So thank you for that. So look, the next three presentations are sort of mini case studies, and I just apologise in advance for giving the speakers so little time to describe.
My name's Michelle. I'm just wondering, I thought I booked an appointment for Emma Johnson, and I can't see it in my diary. So can you let me know if it's there? Yeah, Emma Johnson.
Sorry, someone is booking an appointment for Emma Johnson. You might want to mute yourself. We've got three of these mini case studies, and I know that there'll be more information available on all of them if you want to find out more. So I've really posed a difficult task for people, which is to describe the evaluation a little bit and then to highlight some of the challenges and issues that arose for them. So the first of these is from Liz Hay, who's the Director of Economics and Analysis at the New South Wales Ministry of Health. I think Liz will be known to many people online. She was, prior to her current role, she was the Manager of Health Economics and Evaluation at the ACI, and I think many of us knew her in that role. But again, her more detailed bio is in the material, and we're very pleased to have you here today, Liz, and really looking forward to hearing about the challenge of evaluating the multiple value-based healthcare initiatives. This is an almost diametrically opposed model to the one that Nick was just talking about. So look forward to hearing how it works in practice. Thank you. Over to you.
Great, thanks. Thanks, Sally. I hope everyone can hear me. Just while we go to the next slide, Amanda, I just want to acknowledge that I'm on Bundjalung country up in Lismore, and we've just had the most devastating floods our community have ever seen. So big shout out to everyone who's up here trying to recover. So value-based healthcare, I'm going to do a bit of a case study around value-based healthcare. It is a strategic priority of New South Wales Health, and we have implemented value-based healthcare across the four essentials of value. So that's the health outcomes that matter to patients, the experiences of receiving and providing care, and the effectiveness and efficiency. One of the key enablers of value-based healthcare is measurement, which includes monitoring and evaluation. And really what we're trying to do is shift that dialogue for the patient to focus on what matters to the patient, and to focus, move the focus away from volume, which is traditionally how New South Wales Health has measured things, to value, so outcomes. So the next slide, please, Amanda. Early on, we realised that we had a big challenge across our system. You know, we've got over 130,000 staff in terms of getting consistency in approach. So we developed some measurement alignment principles which have stood us in really good stead, and they might sound pretty basic, and I heard Nick mentioning basic things before, but often the basic things are the ones that stand us in good stead. So some of those, I'll just call out a couple of those principles, but around measuring what we should, not just what we can. I see so much measurement go straight to where the data exists rather than taking a step back and thinking, well, what do we really need to measure to be able to determine impact and whether we've provided the outcomes that our patients needed. Following on from that, having that one set of aligned and consistent measures. The other thing, I think New South Wales over the last few years, particularly with our Bureau of Health Information, we're really moving to that transparent sharing of data, so making data accessible and usable to the whole system. Next slide, please. So that's a bit of an overview. So some of the challenges, though, is developing that culture of positive evaluation and recognising that performance is different from evaluation. So we do have a performance framework that's very well understood and articulated. New South Wales Health Ministry of Health is the system manager. And the LHDs are in contractual arrangements over their performance with the ministry, which leads up to the secretary. But they are different. So why do we evaluate? What are our main drivers in New South Wales? So to prove that it's more than just a good idea and to develop that evidence base. Because we have to, and I'll have a talk about our government requirements on another slide, but also to inform future resourcing and future decision making around a particular cohort or service model or whatever we are evaluating. More importantly, though, because we should, you know, if we're really committed to producing the best outcomes for the patients, we really need to be able to assess whether we've delivered that. So that shift in focus around moving to outcomes, not outputs, but also to get the views of the patients and the clinicians. And I'll talk about clinician experience in a minute, but we have stood up the first at scale in the world, we believe, clinician experience survey. So that's been a really important new development in value-based healthcare, and we've been partnering with academics to do that. And the final reason is to decide and assess impact and whether we've achieved those outcomes across a range of different dimensions. Next slide, please, Amanda. And these slides will be available to everyone, so I'm not going to talk verbatim at them. One of the challenges is changing the culture. And I often, because I am an economist by trade, when I have to talk about economics, I often title my presentation, Economics is Your Friend, which makes some people gasp in amazement. And I often find that many clinicians are actually closet economists, so that's always good. I co-design every economic appraisal that we do with clinicians, and that's been a really beneficial two-way relationship there. So economics has a very important role, and as you'll see, our government has recently shifted the focus of evaluation to economics. So we have a range of economic intersections in our evaluation cycle. Next slide, please. Many people, though, believe that economics is about lowest cost, and it's not at all. And I go to great lengths to explain that economists are not accountants, and there's a big difference there. So one of the other challenges has been in New South Wales that research and evaluation, why they intersect and complement, they are different. And you know, evaluation, I've been seeing it, and Sally's been on this journey too, growing as a discipline in its own right. And while research has a place to play, so does evaluation. It's equally as important. One of the things where I see this happen all the time is we've developed a massive linked data set. So ROVE, as it's known, it's a virtual registry. It's our register of outcomes, value and experience. It's set up these public health registries under our Public Health Act, and you do not need ethics to access the data in this data set, and you can publish from it without the need for ethics unless you are doing research. If you are doing evaluation, if you're doing quality and safety improvement, if you're doing planning, you can use linked data, publish it as well in any journal without the need for ethics. So that's just one example, because when we've engaged with researchers, we often have to prove to them that they're allowed to use this data and they do not need to have ethics if they are undertaking evaluations for us. And there's a whole other dimensions there. But I really think this might sound a bit corny, the function, and we are really, research is one of our key enablers as well in value-based healthcare, and we are looking for that kind of translational research, so research that can then help us develop further our value-based healthcare approach. You'll see there some of the cohorts in our Leading Better Value Care sets of cohorts, which form part of value-based healthcare. Value-based healthcare also includes many of our priorities, so election promises such as telestroke, our newest big priority, which is virtual care, and integrated care as well, the commissioning for better value, and our collaborative commissioning initiative. So it's very big and it's growing. Next slide, please. So the other big challenge that's been going on for a while is the changing government evaluation requirements and our landscape. So our Treasury, driven by Treasury, but ably backed up by our Premier's Department, have introduced the concept of an evidence bank. Now, it is not evidence, as most of you on the line would understand. I think Sarah Thackway's here. She's been part of this journey too. Her team are co-leading this. The evidence bank is really around economic evidence. So that's going to pose a big challenge for us in a social portfolio. So there's a new emphasis on economics. There's new evaluation guidelines that are also being developed, new business case guidelines, and the cost benefit guidelines are being revised. So I think there's a few of us involved in this whose heads are spinning a bit at what's happening at the moment, given we've all been also handling COVID. So there's a lot of work to be done in this landscape, and these are all available online, and new investment cycles. So there's a lot for all of the clusters across New South Wales to take into account. That's going to be a big challenge because we will have to shift resources to meet those requirements. Next slide. So this is my final slide. So this is some early lessons and challenges. So I've touched on the fact that evaluation and research are not the same. They intersect and complement, but they are not the same. That we need to measure what we should and not what we can. Even if we don't have the data, we don't have perfect patient-reported outcomes data yet, but we are starting to collect that through our HOPE system. We love acronyms in New South Wales Health. So understanding what you can and can't answer now and in the future is really important when we're designing our evaluations, and getting our baseline collected before implementation, particularly when you are talking about people's experience. So patient experience, which is not patient satisfaction, it's experience, clinician experience. We need to make sure we have baseline around those things before we even implement, because we can't go back and say, can you remember when? It just wouldn't be robust at all. Monitoring is also very important. Governance. Now, governance is critical. Nick touched on that as well. I don't think we've nailed our governance approach yet in New South Wales. The government guidelines are very strong on governance, so that will help us. But really, it is about having that independence in government so that people are not evaluating themselves. Retrofitting evaluations, I've seen so many people try. There's a program in New South Wales Health that's worth several $100 million, and they have to report to government, and they're trying to retrofit an evaluation, and it's just it really doesn't work. So that early design is really important and often a challenge, because evaluation is often an afterthought. It needs to be put into the development of any new program. Needs to be pragmatic, and this is really important. I've seen, and I touch on this when I talk about economics, economics shouldn't be used to bamboozle. We need to be able to use that to be inform government and use it for future decision making. So the triangulated data, which is what our ROVE does, is very, very powerful. And being able to, it's a real skill to be able to present the results in an understandable way. So when we present to our executive, and I'm sure Nick has the same issues, they assume that all the rocket science is done. They don't need a big lesson in methodology. They're very busy people. They want to focus on what the results are and what that means for health. And getting a succinct explanation of that is often a real challenge for some people. It's really quite fascinating, because you would think it would be quite simple. I spend a lot of my time rewriting things and getting presentations right for our executives, so that when people come, researchers included, to present, that they're spot on. that culture of measurement and evaluation, it is quite a new thing. Our Auditor General in New South Wales found that all of the clusters were not providing government with sufficient information to make decisions. So a bit jealous of where Nick is over in the old country, because that they seem to have got that culture embedded from an early stage and have that independence. So that I think it's fair to say that culture is still developing. And as I've touched on, that independence in evaluation is really, really important, and how you do that without making it a threat to people. And it comes back to the fact that evaluation is really about service improvement and also about making decisions, because there is an opportunity cost of everything that we do about how we proceed. Now, I think I'm exactly on time, Sally, so I will stop there.
Liz, indeed, exactly on time, and thank you so much for those insights. I kind of, there's so much in there that's interesting. I was intrigued to hear you say, and I'm sure that a number of researchers online will be interested in accessing the Rove database, which I assume that we can find online or contact you directly about.
It's open to anybody that has a New South Wales staff ID, and that's a Rove Analytics app. But for researchers, the benefit of it is the data's already linked, so they don't have to go through getting it linked by the shell again. So it saves costs. So, you know, we want to just, whoever wants it, we're happy to facilitate that.
Fantastic. Well, that's very exciting, and there's lots of other things I think we want to pick up on. And I was interested in your comments and the way they interacted with Nick's about the way that government operates to set the culture around evaluation, which I think is really interesting. So look, we'll just keep moving through the next two presentations. So I think the next case study is coming from Redman. So Anne is going to talk to us about suicide prevention in Victoria, and she's the director of Evaluate within the Sax Institute. She's was the inaugural director of our program in this space, and she's worked very closely with a whole range of policy agencies in different jurisdictions in that role. She used to be the National Director of Culture and Indigenous Research Centre Australia, and so she's also got a lot of experience in thinking about the way that disadvantage plays into the evaluation. So Anne, thanks for coming this morning, and over to you.
Great. Thanks very much, Sally. Hi, everyone. I'd also like to acknowledge the land that I'm on, the Gadigal people of the Eora Nation, and pay my respects to elders past, present and emerging. So thanks very much for the opportunity to talk. I think building on what Nick and Liz said, I think my case study is going to be kind of diving a little bit deeper. So I'm going to talk about an evaluation we did of place-based suicide prevention trial, and it was much more in that kind of emerging space of kind of a complex statewide initiative that was being trialled in 12 communities across Victoria, which had many kind of moving parts and kind of longer term policy implications. So I'll just share my screen. That will quick. Great. So I assume everyone can see that okay? All right. So what I'll do is I'll start by explaining the program a little bit, and then a little bit about the evaluation, and then end with some of kind of those kind of challenges and implications that I see in terms of where evaluation is heading and the role of evaluation policy and programs. So, all right. So the place-based suicide prevention trial, so as I said, it's a Victorian government initiative, and it came out of their framework for suicide prevention 2016 to 2025. It was a systems-based approach, so being rolled out in 12 communities. And interestingly, which was new for the Victorian government, it was a co-investment with primary health networks. So all 6 PHNs were part of this and worked together. And so there was metro and regional locations and 18 LGAs that were part of it. And the nature of the kind of place-based and collective impact approach to this trial was that it was about kind of locally developing in collaboration with key stakeholders across the suicide prevention system, which is, you know, cross-sector, and also including lived experience voices as an important part of the implementation and also kind of the evaluation as well. It was implemented from late 2017 to June this year, and it had a kind of statewide operating model, and critical to this was around looking at suicide prevention strategies that are informed by evidence, so including the kind of lifespan model. So that was a critical characteristic of the implementation of the trial. And as I said earlier, it's multi-level, complex, it was evolving and adaptive. So how it was to be rolled out in each community was about tailoring it to that community, their existing capacity in terms of suicide prevention and mental health services more broadly, and adapting that in terms of the design and implementation. Broadly, there were kind of two overarching goals of the trial, which was looking at improving local suicide prevention systems and also improving kind of individual suicide prevention capacity within those communities, with the longer term aim of reducing self-harm and suicide. So we, in the evaluation, were really focused on looking at changes to the suicide, observing and documenting changes to the local suicide prevention system, and looking at kind of changes in terms of individual suicide prevention capacity. It was a multi-phase evaluation. So we started around when the trial itself started, so in 2017. And the first phase for us was working in collaboration with the PHNs and the department and community governance groups to kind of design the evaluation framework. So there was a very extensive collaboration phase as part of that, and then the initial evaluation was looking at the establishment phase. So that was a developmental evaluation approach where we're really trying to understand the nature of the kind of relationships and implementation and design at kind of the community level, and then how that looks in terms of the statewide implementation of the trial. And then there was a formative phase evaluation, which was a process or implementation evaluation, so looking at progress and factors that we're implementing that were influencing progress, and finally looking at a summative phase evaluation, which was, you know, how did go in terms of looking at outcomes achieved and factors that influenced outcomes. So I think Nick touched on earlier about being involved kind of initially in that initial kind of trial phase. So this is a good example of having kind of evaluation there from the start and us being involved in that initial developmental evaluation through to having the summative evaluation at the end. So in terms of methods, it's mixed methods, and there's a whole range of data sources, but the main ones I want to just touch on briefly was around getting and developing really good monitoring data systems. So having a kind of trial that is developed and implemented very differently in each of the communities based on kind of need and existing infrastructure in terms of mental health. So we set up kind of systematic and consistent reporting templates that each of the site could use. So from the outset, we had really good quality implementation data, and it also looked at kind of partnerships and relationships and mapping those over time, as well as activities and some data around successes and challenges and resourcing and so on. That was all part of that monitoring data. There were community and stakeholder surveys that coincided with those three phases of the evaluation, so we could look at change over time. And similarly, there was a significant qualitative research component, again, over those three time points. And in the summative phase, then we did mixed model analyses to be able to look at factors that influence progress. Okay, I'll talk very briefly about a couple of findings, but more as a lead-in to kind of provide some anchor for the discussion of some of the kind of challenges and considerations for us in this evaluation. So I think there was evidence from all of the different data sources around a strengthened local suicide prevention system, and you can see there that looking at how we kind of defined and measured suicide prevention system had a number of characteristics. So we looked at aspects in terms of being locally tailored, being a partnership approach, coordinated approach, evidence informed, effective and adaptive governance, and inclusive governance. So that initial kind of role within the evaluation of identifying what an improved suicide prevention system would look like and looking at the evidence and from collaboration, these kind of key characteristics were identified, and they were kind of measured throughout the evaluation over the 3 phases. So there was evidence of that. There was also, just to give you a sense of scale in terms of the kind of implementation of the trial, so I think there were over kind of 350 partnerships and relationships and organisations and individuals, including people with lived experience, who were involved in the trial either as participants or more directly involved in the implementation across the sites. There are almost 400 suicide prevention and resilience promoting activities implemented as part of the trial, which meant that there were over 170,000 participants who accessed and participated in some capacity building activities, and more than 150,000 who participated in kind of resilience promoting activities. So I guess that's a sense of the kind of scale over the years. The other key outcome that we were looking at in the evaluation was looking at individual suicide prevention capacity. So in the qualitative and also in the surveys, we were asking kind of self-report around individual capacity. And again, as part of the evaluation, looking at the evidence and the collaboration in the planning process, we were looking at what are the indicators or what measurements that signify improved individual capacity to support experiencing suicidality, and these were identified as awareness of supports and services, comfort talking about mental health and suicide, knowing how to talk or write safely about suicide. And that's important because actually in quite a lot of the sites, they worked a lot with media around suicide, which was a really important initiative. Also looking at being able to recognise distress, being comfortable asking kind of friends in need, being comfortable asking colleagues in need, understanding the risk factors and knowing how to respond to suicidality. So the evaluation found that there were improvements in that kind of self-reported suicide prevention capacity, and the improvements were most significant looking at awareness of support services and resources, knowing steps to take if someone expresses suicidality, and comfort talking about mental health and suicide. So I'll go now talk about some of the kind of considerations for evaluation, kind of challenges, reflections from this experience. Also, before I go on, I'd also like to acknowledge, obviously, doing an evaluation. This evaluation was very much a team effort, so it was kind of led within the Sax Institute by Sally Newell, who's an evaluation fellow within our team, and we also partnered with Monash University, and they were partners with us from the start, which was really fantastic. So Fran Scheuer from Southern Synergy, and also Brendan Johnson, who was a lived experience researcher. So I think having that kind of mix of skills and expertise was really important in this evaluation. So there are 2 main considerations, and I think the first one builds a little bit on kind of, I think, what Nick was talking about in terms of, you know, the different types of relationships in terms of being kind of embedded on one hand and being completely external and independent on the other. So I think one of the strengths of this approach was having the evaluation embedded from the outset, and I think that's long been recognised in evaluation as an important way to be able to kind of design and implement an evaluation so you get good quality evidence. But I think for us, what was different was that initial involvement in that program planning and implementation phase. So we started when the trial itself started. So I think it was not a blank canvas, but for looking at how it was going to be implemented in the sites, it was open in terms of how best to design and implement the trial within all of the 12 communities. So I think we played a really important role, and also a challenging role, in working collaboratively to really identify and define what an improved suicide prevention system would look like in communities, and what it means when we're talking about people and individuals within those communities having improved capacity to support people experiencing suicidality. So, and I touched on some of those indicators earlier in our discussion. So I think that was a really important role for us as evaluators in that, and you know, we were kind of one of many kind of forms of evidence and collaboration to determine that. But I think applying that evaluative thinking in that early stage was a kind of key role, I think, for the evaluation. The other thing that was different was we were also, because the evaluation was embedded from the start, it was clear that we had a role in terms of influencing continual improvement. So having good feedback loops and providing ongoing evidence around findings and implications was a really important part of our role, and that influenced kind of the design of the evaluation, but also the kind of ways that we looked at translating the evidence and supporting that kind of shared learning. And in terms of the third point, I think one of the challenges is working in those grey areas. I think for kind of in evaluation, where often the parameters and goals are often very clearly defined, and even implementation are often quite clearly defined when you're looking at how best to evaluate this and what are the best methods and best evidence that can answer the key evaluation questions around kind of implementation and outcome. But when it was kind of an adaptive and evolving model that really, you know, is a grey area that required some comfort from us in terms of working in that kind of uncertain space, and also it meant that the people that we were working with, especially those who've been recruited to implement the trial on the ground, were also in a similarly uncertain space. So we're kind of adapting and learning together as part of that. Not surprisingly, considerable time and collaboration is needed to work in this way in terms of evaluation, and as both Nick and Liz touched on, that whole pragmatic approach to evaluation and being clear about what data should we collect as opposed to what's available. And because this was a new trial in the 12 communities, it was really a lot of time spent on working out what data could we collect that would answer the evaluation questions. And the final point I wanted to make here was about our role. Nick's talked close distance, and we've kind of talked about it in terms of a critical friend. So I think there's possibly quite a few similarities in those concepts. So I think, you know, our role is to provide rigorous evidence and to be objective, and that's kind of really critical. And I think that's a core to kind of conducting evaluations. But we're kind of working closely with those involved in the implementation, and that means that we have also a kind of clear role in terms of highlighting kind of successes and challenges and I guess airing difficult conversations around or concepts around some of the emerging evidence, and being clear of our kind of role there.
So Anne, we're sort of out of time. So do you have many more slides, or are you nearly done?
Sally, one more. And this is just, and I'll just touch on this briefly, but this was really about our other role in terms of supporting decision making across the system. So we looked at lots of different ways of providing that evidence at both the site level and then at the statewide level. So given time, I'll finish there. Apologies, Sally.
It's fine, Anne, thank you. And also highlighted lots of really interesting points. And I like this juxtaposition of a critical friend and what's Nick's term, a close and distance. So really great. And I think perhaps we'll just keep moving on now. So thanks for that, Anne. And now I think we have Luke. So Luke's a behavioural scientist. He's an NHMRC investigator fellow at the School of Medicine and Public Health at the University of Newcastle, but I think also has a relationship with the local health service, so the LHD, and has worked closely with policy for a long time. He's also part of the Australian Prevention Partnership Centre, so it's been very interesting to see his work in that space, which has been very powerful, I think. So Luke, over to you. Great to have you here, and look forward to your comments on this interesting work.
Thanks very much, Sally. Really excited to be presenting today. So thanks for the invitation. So I'm presenting today on learning health systems for prevention, and I think this touches on some of the issues that were raised by the previous presenters, where evaluation is used, you know, not merely as an opportunity to generate new knowledge and for accountability, but also as a tool for improvement. Just waiting for my screen to move. There we go. I just want to start by acknowledging the traditional owners of the land that we're meeting on today and pay my respects to elders past, present and future. I'm on Awabakal country here in Newcastle. So the etiology of chronic disease and its risk factors are incredibly complex. There are multiple determinants that operate at different levels and interact, and many of you will be familiar with the foresight map on obesity, a system map which kind of looked to identify the primary determinants of obesity. You don't need to be able to read the boxes there in that systems map. The point is that it's tremendously complicated. And so both our population health interventions and their evaluations are also complex. Unfortunately, when we evaluate many programs that have been implemented to routine practice or evaluated under real-world conditions, we find that many of them aren't having beneficial effects on the population. Some work by Megan Finch, Serene Jung and others have found, at least in my field, obesity prevention and physical activity effect sizes of programs that have been evaluated under real-world conditions, typically between half and a tenth the effects of those interventions that are tested under more ideal research conditions. And there are a number of reasons why this could be the case, but it's often attributed to a poor intervention fit. So we're investing in the development of interventions that may rely on expertise or infrastructure or resource that actually aren't available in the setting in which it's intended that they're delivered, or a lack of an effective implementation strategy. So there may not have been a thought out and effective strategy that was capable of achieving implementation of the intervention with sufficient fidelity to yield a public health level improvement. And so in order to achieve population health impact, we need to identify and use effective interventions and effective strategies to implement them. But identifying these and identifying those that are suitable for your local context is a real challenge. The effects of interventions and implementation strategies are often really heterogeneous. Anyone who's used systematic reviews for public health policy or practice decision making will be familiar with the forest plot on the right hand here. So for those of you that aren't, so this is a meta-analysis that's been undertaken as part of a systematic review. This particular example was for physical activity interventions that have been implemented in schools. Each of the horizontal lines represents a study, and the little dot in the middle of it represents the point estimate of the effect of that particular intervention. So here, every dot on the left of the vertical dark line is an intervention that is not beneficial or is ineffective in improving physical activity. Everything on the right is an intervention that had a point estimate that was beneficial. The lines represent the confidence intervals. So we've typically been trained to simply look at the pooled estimate of effect, so the combined estimate using all of that data. And then in this instance, we can see that the pooled estimate also crosses that dark vertical line, which suggests that physical activity interventions in schools aren't effective. What we do know, though, is that contextual factors can sometimes be better predictors of the effects of interventions than the components of interventions themselves. And if we interpret the effectiveness of interventions just based on these pooled effects, then it can leave policymakers with few options to address, wicked problems like physical inactivity. And pooled estimates of effect don't adequately account or consider the context in which interventions were delivered. And so we may need more nuanced appraisals of interventions to inform their selection in our local context. So it might be, for example, we consider the pooled effect, but we also look for interventions that have worked and the context in which they've worked, and whether we think that intervention might be appropriate for the community that we're serving. So the current methods of generating evidence for informing public health practice are tremendously inefficient and can lack, local external validity. Science itself is a cumulative industry. Progression is slow and incremental in public health. with relatively few exceptions, there are rarely kind of breakthrough scientific discoveries that kind of transform public health practice. Usually what happens is that new knowledge is slowly created and we learn from past studies to build effective interventions over time. This process can stagnate in instances where it's difficult to learn from past studies. And as I showed you before on the forest plot of systematic reviews, there's often a large number of interventions that are undertaken, but also considerable heterogeneity, which makes sense-making quite difficult. The graph on the right-hand side here shows in the blue bars the number of randomised controlled trials of school-based obesity prevention interventions that have been conducted. And as you can see, there was 120 in 2017. There's probably close to 200 now. And from a person who's worked in that field, I can say, despite that considerable investment in randomised controlled trials, we don't actually know, a lot about what interventions work in what types of contexts. And so we really need new models for research production where research is conducted in the context in which it's to be applied and with people or end users who are going to apply it. We need to employ harmonised methods where possible that allow us to really efficiently build off studies that have been undertaken prior, and that also open up more sophisticated methods of evidence synthesis where we're better able to identify effective interventions, their componentry and the context in which they work. And we also need to seek to contribute to the generalised evidence base. So we think one opportunity to do that is through moving the evidence generation process into the health system itself, or at least more so. And this is kind of encompassed with this idea of learning health systems that is gaining a lot of traction, particularly in medicine. So learning health systems are processes where there's continuous improvement and innovation, with best practices seamlessly embedded into the delivery process and new knowledge captured as an integral byproduct of the delivery experience. We recently undertook a consensus process to come up with a definition of optimisation, which we think is a method which can be used, an evaluation method which can be used to contribute to public health operating like a learning health system. And optimisation we defined as deliberate, iterative, data-driven processes to improve a health intervention or its implementation to meet stakeholder-defined public health impacts within resource constraints. And so this is really where research is undertaken in a systematic and iterative process. You can see the ribbon on the right here is trying to kind of graphically illustrate how this might occur. So we do a trial, we comprehensively evaluate it, we adapt it, and then we go again. And we continue that process until the end user is happy with the effect that has been achieved as part of that intervention. And this process is really looking to achieve what they call radical incrementalism. So we really want to turbocharge the process of improvement from a series of unconnected studies that we try and make sense of through a systematic review to a series of directly connected studies where learning occurs in the context in which the intervention is delivered. So we have applied this approach in a number of instances in a public health unit in the Hunter, New England region. In this instance, researchers are embedded within the health service and are responsible both for the development and evaluation of health services. So they have accountability to the health service as well as accountability to the university. So they're individuals with joint appointments and dual responsibilities. And we've demonstrated in a couple of case studies the value of this optimisation type approach. Both of these examples have used sequential randomised controlled trials, the process I described it on the slide earlier. And over 3 randomised controlled trials, we optimised a healthy lunchbox intervention. So this was an intervention that was originally developed using traditional health promotion planning frameworks. Took a whole school approach. We provided curricula, we provided resources to parents, lunchboxes, ice bricks. We sent messages via text message to parents with interactive content to provide some support around how to pack a healthy lunchbox. Over 3 randomised controlled trials, we essentially identified that the effective component there was the text messages only, and we could achieve the same effect size as the original comprehensive trial at about 5% of the cost. So that was a tremendous improvement in the efficiency of our health service for that intervention. We also did a similar sequential randomised trial, again over 3 phases, where we optimised the approach that we took to improving the implementation of healthy canteen policies. So these are policies that restrict unhealthy food availability at the canteen for students. And we essentially doubled the effects of this implementation strategy, but were able to do it at half the cost at the end of this sequential trial. So I'll just leave you with a couple of thoughts about, our reflections on this process and what we've learnt. On the whole, it's been an approach that's been remarkably successful, and I'm really convinced that, certainly at least for our service, that this is an approach that we should continue to develop, given its success. I think in the past, if we came across an evaluation finding that suggested that an intervention or a model of its implementation was ineffective, we may well have abandoned it, and the opportunity cost from abandoning interventions that it could be tweaked with some good process evaluation and further follow-up, is a tremendous opportunity cost and a resource waste. However, sequential randomised control trials still take time, and they still cost money. While we've embedded into the health service infrastructure, we think that there are opportunities to abridge the time it takes to identify, an optimal intervention through different types of approaches, which I can speak to in the question time. We also find that effect sizes diminish at each phase, and that requires increasingly greater samples. So there's some methodological challenges to this type of approach. The mechanistic understanding of an intervention or an implementation strategy is elusive. It's actually quite difficult. Sometimes what you think are the core components of the intervention are not. And so, you really need to kind of triangulate your points of view when you're triangulate your data in order to identify what needs to be adapted between phases in order to optimise your intervention. And doing this using statistical, mechanistic and economic approaches or insights is really useful, but is also a considerable challenge. Thank you.
Thanks, Luke. That was fascinating, and I look forward to hearing more about that, as I'm sure there'll be questions to you about that. So, well, someone's clapping, that's great. So now I think we're going to throw it open to people to ask some questions. So I'd like to just ask the panel members to turn on their screens and their mics so we can easily flash to you to answer questions. So if you've got some questions for our panelists or other issues that you just want to discuss more generally, please use the chat functions so that we know you're there. I think that I might kick off with a question of my own while people are getting themselves organised. But I wonder, we're also really pleased that we have online Adrian Bowman, who people would know Adrian's work in evaluation for over many decades, Adrian, and also Sarah Thackway from the Ministry of Health and Alan Singh from NHMRC. So if you have a question or an issue or comment on the presentations, we'd be particularly delighted to hear them. So so do let us know. I don't want to put you on the spot by directing something at you, but please let me know if you'd like to ask a question. So Luke, we might just start. There's a couple of questions on the chat line, actually from Andrew Millat and Robin Newson about the approach that you just discussed. So Andrew's asked, do you think this optimisation approach could be used across LHDs to create a larger laboratory? And Robin is interested in the process you go through to consider scalability at the start of the optimisation process. I might like to take those two first.
Sure. In terms of the the approach being used across other local health districts, we're actually conducting we're trialling that at the moment. So we have 3 local health districts that are currently implementing or responsible or currently interested in delivering the same school-based intervention, and they're trialling different methods using a harmonised evaluation approach. And the idea is that these 3 trials will be thought of as a network, and there'll be learnings from each trial fed across to the other participating local health districts. So that rather than sequential randomised controlled trials getting to the point of an optimisation, an optimised intervention, we can undertake simultaneous randomised controlled trials undertaken in different contexts and share that information so we get to the point of an optimal intervention for particular context at a much quicker rate. So yes, that is occurring at the moment across 3 LHDs. We've recently established a research and evaluation network which includes all local health districts in New South Wales. And one of the ambitions for that network is this type of work is undertaken through shared infrastructure across all LHDs. So there is some thoughts about how we could build the capacity for LHDs to operate in this way and share their research findings. So in terms of Robin's question regarding scalability, certainly when we started this approach, we didn't have the scalability assessment tool that Andrew Millat and others have developed. We certainly considered issues of feasibility, for example, of interventions and their capacity to be implemented. But I think going forward, using formal scalability assessments and tools like the one that's been published by the ministry would be a really sensible idea.
Thanks, Luke, and a lot of interest in that presentation. Look, Adrian, would you like to? Actually, we might do the 2 others for Luke first, and then we might come to the question to Anne. So I think there's a few more questions for you, Luke. So one of them is, well, it's going too fast for me. Why don't we start with Nick? Nick, do you want to ask your question of Luke?
Yeah, how's it paid for? Who pays for this this embedded activity?
Well, it's jointly funded. So we have people funded through the university within the population health unit. So they might be funded by independent fellowships, but it's also funded by the health service themselves, who fund the other fraction of the position. So that's the staff. We also leverage the work that's undertaken by the health service to attract external funds from NHMRC and others to support the work and add rigour to the evaluation. But essentially, this can be undertaken in some form through health service infrastructure, particularly if we see evaluation and learning through evaluation as a critical and core component of best practice public health, which I think we should.
So thanks, Luke. So that sounds like a lot of hard work, actually pulling all those relationships and funding sources together. So I guess thinking about that, knowing that we have Alan online, and thinking about the value of the partnership grants, perhaps, and facilitating that kind of work. So it's great. I think actually Ellie House has asked a question about really for everybody on the panel about she said, how do we characterise the relationships? And I think asked a question about, are there certain research or evaluation questions where one kind of relationship might work better than another? And Nick, I might ask you to lead on this, because I know that you've thought a fair bit about this.
I think it's a good question, an understandable question, but I think it's the question about whether there are certain kinds of evaluation topics or questions that are better suited to one approach over the other. The problem there is that I think the different approaches require prior commitments and relationships and institutional development. So I think it would be very difficult, for the English policy research programme to suddenly flip into an embedded model for a particular topic. And I have tried it. So when my unit we were pitching in 2009 for the Policy Innovation Research, and because of the nature of the work we were being asked to do in the remit at least, I thought that it would be good to, for example, have a program of secondments and exchanges with some of the policy teams in the Department of Health, and so on. And partly to sort of stir things up a bit, and partly because it was different from the conventional relationship that I described in my talk. Actually setting that sort of thing up for individual projects is probably, in my world, not really feasible. As it turned out, we couldn't even set it up as an ongoing activity. It was just too complicated to try and get two bureaucracies, i.e. a group of universities and central government department to think of how they could organize this kind of thing. We also realized that career incentives often contradict one another in these sorts of relationships. So I would say, in principle, I like the question. I like to think about whether there are certain kinds of evaluation questions or more or less politically charged issues that could be dealt with differently. But I do think it actually will depend a lot on the prior decisions and commitments and funding and that you've already made to your particular system. I mean, I guess in a large health and policy system, it'd be nice to think that there are a number of different models, perhaps in different places. So, you know, in New South Wales and in different health systems and universities, maybe people are doing different things. But I think pivoting from one to another, I can't see how that would work, really.
So interesting, Nick, and I wonder if anybody else on the panel wants to make a comment on that.
I might, if that's okay. Sorry, I was just getting off mute. So when we design our evaluations, we start with a blank slate and we co-design with our clinicians and our patients and our other stakeholders from LHDs. Having said that, we do have, I guess, with value-based healthcare, we are evaluating across those 4 dimensions of value, and the clinician experience one's the one that we've kind of been least focused on, but that's changing now. There's also, from a public perspective, the need to make sure that we are providing sufficient information back to government, given that it's the taxpayer dollar that's invested. So we're probably a little bit more constrained in the kind of questions and our approach than kind of Nicholas with the purely independent kind of model, which is great. So yeah, there's often some tensions there, but we get there in the end. The one thing we do like to start with, though, is our program logic and defining our outcomes and getting the evaluation questions from that, rather than the other end. People often start with the data. I see it all the time, but starting from that program logic and co-designing that is really, really important for us.
Thanks, Liz. And yeah, so I think you're both talking about, process and context as being really important in terms of how you set the evaluation up and how you think about it. Adrian, I see that you've asked a question, Adrian Bowman, and I think you should be able to turn your mic and camera on to ask that question.
Thanks, Sally. In the last few months, I've been involved in advising 2 systems approach evaluations in the UK, and they were community-wide interventions, and they'd both been going for 10 years or more, doing systems development in the way. And I asked them, well, when are you going to measure outcomes, i.e. the health outcomes you're trying to change? And it was a whoops moment, because I realized I said something completely inappropriate and there was silence for a long time. So I just wonder on Anne and perhaps Nicholas's reflections on that.
Thanks, Adrian. Good question. And of course, the downstream things are important, but you've got to get to the crunchy point at some point. So, Anne, do you want to respond first?
Yes, so it was interesting because in the evaluation planning process, that was part of the discussion and our recommendations. So there was clear evidence in terms of from the Black Dog Institute and others that it would take at least 5 years, if not more, to expect that you could reliably look at any kind of change in suicide rates and look at the attribution. So I think, there's probably some recommendations of the appropriate time in 5 to 10 years. And I think in place-based approaches, the challenge is always, especially because a lot of the communities were kind of smaller rural communities. So even just the kind of the data itself makes it very difficult to look at those end outcomes. But and obviously attribution is one hand. But I think we did recommend a like summative phase version 2, which was to be done kind of in kind of 7 to 10 years, which then would be looking more holistically at those final health outcomes in terms of reduced suicide rates.
Of course, because there's no control group as time goes on, it becomes increasingly difficult to attribute those, decreases in suicide, say, to that particular intervention. So I think it's quite an important and challenging question that Adrian's asked. Yeah.
Yeah, and also I think in Australia and I think internationally, there's been a lot of focus on suicide prevention across all levels of the government too. So I think it is a very, important and high priority space at kind of like from local government through to national government as well.
Thank you.
So there's lots of activity in addition to this. Yeah. Nick, did you have a comment on this?
Yes, I mean, obviously don't know which programs Adrian's been advising, but I think they're fortunate to have that good external advice. But yeah, I mean, I've just been coming to the end of an evaluation that's been going on for 6 years, and in a sense, we in the evaluation community in health policy research in the UK were advocating 5 or 6 years ago for longer term evaluations, and unfortunately, I was lucky enough to be the PI of one that was awarded. And it's been really, really difficult. I mean, part of the problem is the bigger the more kind of oomph there is behind a particular program, the more likely it is that actually by the time it's been going a few years, everybody's trying to do it. So your idea of any kind of comparison sort of begins to evaporate. Equally, if there's political support behind it, and particularly if there's a bit of evidence that says this might be a good thing, everyone wants to do it and no one wants to be in your comparison group anyway. And then if your outcomes are dependent on wider determinants of health as well as the impact of the program, then over 5 or 6 years, the world changes. I mean, look what's happened in the last 5 years. We have economic crashes, we have wars, we have pandemics, we have big changes in the relative funding of health systems, certainly in England. So sadly, I guess we, in a kind of causal sense, a meteorological sense, we'd like to see longer term evaluation, but actually, sadly, the real world is a bit messier than that. And certainly I found it very difficult in this particular study that shall be nameless to persuade sites that are not involved in the program to take part in sort of quasi-experimental studies particularly wherever the outcome requires primary data collection. They're not interested, or they just want to do it themselves and join the program.
So I think Ray Fry, would you like to ask your question? Turn on your, because it relates to this issue that's under discussion.
Yeah, thanks, Sally. It's just about the challenge of attribution and using dose-response relationships in those kind of big systems level or statewide programs. One possibility for attribution is to use dose-response relationships, but we need to understand where implementation has varied and how it is varied in order to do that well. And so getting good data about implementation is really important, but often really difficult because it's often not included in your kind of admin data systems like Rove, for example. So any kind of insights or suggestions about how to tackle that problem? I could see that embedded researchers would really help there, but that's not going to be, sustainable over time in a kind of a system where there's ongoing learning.
Yeah, it's a really good question, Ryan. You can see all the panelists are nodding, kind of their nods of recognition. And even if you're wearing a researcher hat and just thinking about a more controlled environment, then you still often have difficulty thinking about and measuring dose properly, So, I think it's something that we should have focused on more historically. So I saw everybody nod on the panel. So would anybody like to respond to Ray? Nick?
I've done something similar but not quite the same. So yeah, in trying to think about the notion of dose or intensity of implementation and its impact, is to look at settings with more or less conducive characteristics. So a context that you think a priori would be difficult for this particular program. We haven't gone as far as to be able to hang around in the system long enough to then say, well, what would you do to change the intervention so that it fits your particular context? But we've certainly been able to do some studies to evaluate large national programs where there is no obvious comparison, because basically government has mandated that we shall all do this. But to try and understand in what settings would this particular reform work best, and therefore to try and feed back to policymakers and say, you're going to need to provide some extra support if you want the system to work well in these less conducive settings, you know, where there's more complexity or there are more obvious barriers to moving down a particular route that government has already decided. Because we often find that we're evaluating things where there's a very strong political commitment. So we are trying to identify, you know, where does it work better and why does it work worse in certain places, and how might you, in Luke's terms, optimize or make a better fit between the setting and the intervention or the policy. So that's the way I've thought about it. It's a sort of very impure version of dose response, really.
It's kind of a realist approach, context and mechanisms.
Yes, I'm sort of struck because I'm thinking about say interventions to improve, to make a clinical change, and how important, say, leaders are in that space, and how, even though what you kind of deliver from a government or research perspective is exactly the same, you know, the effect of a committed and passionate leader is really to exponentially increase the power of the intervention. So I'm not sure how we think about, say, dose in that sort of context. Luke, you were nodding. Oh, Liz, you go.
No, Luke, do you want to go first, or? Yeah, so I was just going to add in, Ray, you probably weren't around. So with the early days of leading Better Value Care, we did measure, had a whole range of metrics around implementation, and then we were able to link, you know, that I guess the success or lack of it in implementation to some of the outputs at that stage that were being achieved. So it is definitely something that we do focus on as well, and there's a whole lot of work happening around measuring implementation at the moment with some of our research partners. So that is going ahead. The other thing I guess I wanted to say back to Adrian's comment is that that's what we're doing in value-based healthcare. We are starting with how do we measure our outcomes. So we've recognised that is a big deficit, and we've flipped it around to look at measuring our outcomes. Having said that, we do have what was previously known as formative evaluation, now Treasury calling it our process evaluation, which is very much going to focus on that implementation and that early phase as well. So that will put a few challenges up to people, but it also give us a really good opportunity to tweak things as we need to going forward to the next stage. And now our summative evaluation is now called outcomes evaluation. Interested to know that, like Nick mentioned, 6 years of evaluation to evaluate a program in New South Wales, we tend to want to be a lot more timely than that. So we do have our different stages of evaluation, but we do have some very some strong leaders that like things a bit quicker. So that's why monitoring is really important as well, in building up that other set. And Sally, just finally on that point of clinical leadership, that is, you just won't get the change if you don't have the leadership, and that's clinical, but it's also at LHD level. We like to say in New South Wales we have a tight, loose, tight approach, very tight in what we want to want delivered, loose in terms of what how LHDs achieve that, but very tight again in how we measure that. And Luke's nodding because he's probably been subject to some of this as well. So really kind of you've got to have that system, but that's why we are now putting a big effort into clinician experience, because, and that will link into what Ray was saying around implementation. And we've just kind of done a rapid one around virtual care and standing that up during COVID, and it's been an amazing experience partnering with researchers at Uni of New South Wales and Macquarie Uni. So that's been a really fascinating piece of work, because we recognise that that's a bit of a gap. Sorry, go Luke.
Thank you, Liz. I don't know, Luke, do you want to comment too?
Oh, probably just to agree, really. You know, implementation, of course, is important, and there'll be typically a dose-response relationship with outcome, but there are many of those other factors that, that might not be measured that are, critical and often can influence implementation itself or the outcome itself. And leadership and organisational climate are kind of two factors that are really critical.
Mm. And so this speaks a little bit to process measures too, doesn't it? So Nikki Woolley from the Cancer Institute, would you like to ask your question of Anne?
Hi everybody. Yeah, I was just curious about the starting point quite often as it is a single disease with trying to make change and with community and reflecting social determinants of health, etc., but still coming in with a single health issue if that's where the funding stream is. But I wonder if that really best reflects the reality of those communities and their lives, the real life situation. I just wondered if you knew of examples of place-based approaches where multiple health issues, organisations came together to work with that place. And yeah, I'd be really interested to hear about any examples of that and how effective they've been and how they're evaluated.
Yeah, I mean, I am aware. I mean, they tend, in my experience, they tend to be almost single issue focused, but broad cross-sector collaboration and relationships coming together to be able to address that. So I think there have been some examples in Tasmania where they've looked at, and it's not a health outcome, but it was about education. So it was in Ulverston and a couple of communities where they identified that school retention, was a big challenge in terms of kind of health outcomes and employment outcomes and, those broader social determinants of health. So they did do a place-based approach there, which was incredibly broad in the way they tried to address that across all sectors from kind of education and health and youth and schools and so on. So I think there are some examples there, but what we have seen is primarily kind of single issue, but kind of cross-sector collaboration. So in a lot of the communities, as I said, there were hundreds of partners who were involved that were much broader than the health and mental health systems. So yeah, but I think it's also a relatively emerging field, although there's more happening probably in the last 5 to 10 years than it was even when we started this. So I'm sure the kind of quality of evidence is going to be building, and there'll be the bigger questions about, in terms of the resources required in the community as well, in terms of supporting initiatives like this.
Thank you.
Yeah, that's interesting. And Ellie House, I don't mean to put you on the spot, but if you're still there and feel you could comment, there's been a lot of work the Prevention Centre's been doing around co-benefits, which I think is really related to this, that we might be focused on one issue, but we might see benefits more broadly. Are you still there and would you like to comment? Great way to embarrass people. Sorry, Ellie. Luke, you've been a bit involved in this. Do you want to comment on it or shall we move on?
Come here. Come.
Hello? Someone there? Luke, do you want to unmute?
Sorry, could you, Sally, can you please ask the question again?
It's just that, I know the Prevention Centre's been thinking a lot about co-benefits and how you measure those when you're thinking about evaluation of a preventive health measure, for example. That, yes, it may have impacts in the health sector, but there may be impacts beyond that in finance or design or whatever. I just wondered if anybody wanted to comment on evaluations that kind of try and measure the kind of impact more broadly and across sectors. But I think I've gone off on my own stream here, and I think Ellie, who's been thinking about it, has left. So I might return to the chat line, which might be safer. So, and you've made a couple of comments about health action zones, which is sort of nearly as good as arm's length organisations. And I think also there was another comment that you made earlier about the capacity to publish quickly, even if it's a long-term evaluation. So do you want to just comment on those two things?
Yeah, well, I didn't. I mean, I think if one obviously wants to know about outcomes over the long term, then one has to do long-term studies. But that doesn't necessarily preclude providing, early continuous feedback. So I would say typically, again, in the sort of world that I inhabit, or the one that I described in that presentation, there's an onus and an expect on the researchers, to feed findings back in a variety of ways. Really, sometimes the early ones tending to be sometimes quite informal and often in private, to be honest, on request, but certainly available. So all my postdocs would expect to, at 48 hours notice, produce something if necessary. It might be a slide set, it might be a 5-minute walk through some graphs with all the caveats, so that it is that idea of the close distance. And at the same time, if we're going to try and publish anything, and everything we do is published, by the way, that's the expectation. The MIHR, makes a big deal about peer review, sometimes to the point where it does slightly slow things down if you want to get them out to the wider world, rather than a small kind of confidential meeting with some senior policy managers. But yeah, it is quite a fluid relationship, and also projects vary tremendously in scale and scope. So my shortest project was 24 hours. It was an overnight job. It was like being back at university.
Luckily, you're awake a night owl.
Yeah, that's right. That's right. I picked my rock and roll lifestyle. That was fine. I was okay.
So look, there's also a few comments coming through about sort of around the issue of independence, and Nick just touched on that to say this might be a good moment to try and unpack some of that. So it kind of came through in all of the presentations. They really represent 4 quite different models of working with policy agencies. So probably with Nick's at one end and Liz's at the other. So I wonder if so Emily Kleinberg has asked a question about how is independence maintained in the evaluations where you've got people embedded. And I just wonder, having heard each other's presentations on it, whether we could just go around the panel and just reflect on this question of what I think, Nick, you're calling it close distance. Yeah, and I think Anne referred to it as critical friend. So maybe we could just reflect on this a little bit, and what might be some of the mechanisms that people use to clarify where they're sitting on that continuum at the outset, perhaps. So would someone like to kick off? Maybe do the order that we did at the presentations. And Nick, would you like to start?
I mean, in the sort of policy research program world that I described, the nature of the relationship, and therefore the degree of independence, or the nature of what constitutes it, changes through the life of a project. So, if you like, in the conduct of the research and the evaluation, we are very much left to our own devices. Not in the sense that we're kind of ignored or we're treated as being in the ivory tower. No, we could be put under quite a lot of pressure to produce findings and to do things rapidly and so on. But for example, the Department of Health rarely or never, in fact, I don't think has ever specified the methodology that we should use to do a study. So they might comment, and they might suggest, oh, have you thought about this? Have you thought about that? But they don't try and second guess us. Other government departments in England are much more prescriptive. They when they commission research, they commission, the person and the method, and sometimes they provide the data and they tell you how you're going to analyze it. And all that they're buying is the fact that this is not being done by analysts inside government. Therefore, they're buying the kind of credibility of the outside analysts. In health, the long tradition is rather different, and possibly because of the academic medical community and so on. They're buying the whole package, and that's done independently. The negotiation at the front end can be quite close to, this is what the policymaker is interested in, and they're not interested in X, Y, and Z, but they're interested in A, B, and C. What we normally do in that context is actually smuggle A, B, and C into the X, Y, and Z, or vice versa. So there's usually a scope to also bring in additional things, often because, in fact, a year on, they're quite grateful that we did look at some of the things that were not priorities at the time. because of course we also pitch projects to the department. So, and quite often we might get no takers early on. They say there's no customer in the department, that's not a priority, and we just keep bashing away. And eventually, you know, sometimes, quite often, they say, yeah, gosh, yes, that's really important, and I'm so glad you've done the prior thinking, and yes, we do want this work. So that's again about the continuity of the relationship. But I would say that the conduct, we're largely independent. The scope and scale and timing, that early negotiation, we're not at all embedded, but we are dependent on the context. If we can't find a client inside the bureaucracy, by and large, it doesn't happen. We don't do it.
And there's practical reasons as well as other kinds of reasons for that, most likely. I mean,
oh yeah. I mean, yeah. But sometimes things are we get quite, you know, we got some things are out of scope, and colleagues say, "Oh, that's a real weakness. That's a real shame." Or the peer reviewers won't like that being out of scope, or it looks a little bit like a two-legged stool. You know, we're missing the third leg, as it were. And you know, sometimes we push back, and sometimes we win the argument, and sometimes they just say, oh, "Okay, we trust you. You know, you can do it, and perhaps in the long run that'll be a good idea." Other times you get a pushy policymaker who thinks they know exactly what they want, and they try it on. You know, they try and sort of push you around, and I have to decide: do I push back, or do I say okay, or do we do something slightly below the radar and make sure that the other issue is actually tackled, even though it isn't explicitly described?
So these are sort of ordinary challenges of working in relationships with colleagues.
Yeah.
You know, regardless of where they come from. You know, the sort of challenge of when you just wave your hands, as opposed to sort of feeling this is something that's really important. So Liz, do you ever get questions from Treasury about independence? Or
yeah, so that's a big focus of our work at the moment. So and trying to separate it out into the design of your evaluation. It is really important to have expert input into that. So I'm not a clinician. I don't know what is clinically appropriate to evaluate. So we need the clinicians involved in whatever cohort it is to give us input. And telestroke's a really, really good example. If I had to design the clinical part of that evaluation, it would be laughable. And likewise, I don't pretend I know what's important to patients. We need patients to tell us what they would like to see evaluated as well, and what outcomes are important to them. And then we have the other set of people, which are implementers, so, and our program designers. So that's important to a certain extent, not as important as having the clinicians and the patients involved in that co-design, even though they have a vested interest in the service, for example. Once we've moved through that design process, so our guidelines are very clear that the people that have designed and implemented the program should not be involved at all in the evaluation. They need to be totally out of it and at arm's length. That's something we haven't done well in health yet. I think we're getting the co-design is getting better with our patients and clinicians, but that, you know, kind of doing an arm's length evaluation away from the program owners is something that we are working on. So Andrew Millat and I work very closely together. I think he may or may not still be online. We are looking at taking to our executive the notion of a totally independent governance for all of our evaluations. So we have a panel that will have governance role for every major evaluation that we do in health, agnostic of whether it's for cardiac or for stroke or for cancer. So that's one of the things. And then, of course, we would have some fluid membership there with some experts, but we may get experts from other states in who don't have a vested interest in what New South Wales are doing. So that's what we're looking at. So we are taking it really, really seriously, particularly around the governance of evaluations. And that will be a big cultural change for New South Wales Health as well. But as I said, the co-design part of the evaluation is very important. Unless you happen to be a patient, a clinician, an economist all in one, you can't design it without getting those kind of stakeholders involved. But then that arm's length governance and arm's length conducting of the evaluation is really, really important. So yeah, I'll leave it there.
That's great, Liz. And I just, Andrew Millat, I think you're still online. Would you want to comment on that or anything else?
Thanks, Sally. So in terms of independence, I mean, I think it is a constant tension because in many ways we've invested a lot of time and energy into the idea of co-production, but by its very nature, we do influence one another. So I think independence of the work that we do is a very important thing, and I think the way that Liz has described of sort of managing that tension is a good one. I think that co-design happens at the beginning around methods, what is feasible, what is appropriate, factoring in what is the budget and taking in different perspectives to see whether those methods that you're proposing are not only scientifically rigorous but realistic in the real context that you're working in, and then doing the evaluation itself in a more independent fashion. But certainly, I think fully independent evaluation, from my own experience, from a translation perspective, often is less likely to get the outcomes, particularly if there's no involvement of policymakers and end users in the design phase. So, and there is a little bit of growing evidence around some of the benefits of that co-design process. I just think it has to be done well and appropriately, and that right balance between independence, and one way to think about it is to have that engagement in different stages of the evaluation process.
Fantastic. That's really helpful, both Liz and Andrew. Anne, do you have comments on this?
Yes, yeah. I think probably the example I gave you in terms of the place-based suicide prevention trial, where the evaluation was embedded within the program. It did still require, so our role as evaluators was still to have that independent lens, and I think being able to have kind of rigorous and objective findings that we could use as that evidence base to provide recommendations was really important. But I think we were working closely with people with lived experience, the implementers and the decision makers, definitely in that co-design phase, but also in that ongoing phase. So I think it is a potential conflict that I think as evaluators you really have to be very clear about. And I think in the evaluation planning, like Liz was saying, that we're also really clear in our frameworks in terms of the kind of rationale around the methods that we're proposing and what questions they'll answer and the strengths and limitations. So I think if you're always, as the evaluator, you're always wanting to rely on the evidence, but you can also have to be clear when the evidence, is going to be limited in terms of different evaluation questions. And I think in the end, there'll be other evaluations where I think it is much more critical to have that arm's length approach, because you want that co-design at the beginning. And like Liz says, you want to step away from those who are implementing it. But in some cases, those who are implementing it are important audiences for the evaluation, because you want them to act on the evidence. So it is a little bit kind of horses for courses, but I think, as evaluators, that objectivity and is critical to everything we do.
So thanks, Anne. Luke?
I mean, I've learned a lot from this discussion. It's obviously with an embedded model, it's we don't separate or disaggregate research and the evaluation part from the conduct of the evaluation from the intervention kind of development and delivery. And in fact, it's probably seen as a strength that we are heavily involved in co-production. We have often the same individual responsible for developing the program as responsibility for its evaluation. And I think there's a number of advantages to that process, particularly, not just in ensuring that the design fits the intervention well, and that the intervention findings or the trial findings are interpreted for improvement. However, I guess I take on board a comment about the importance of independence, and probably on reflection, I think we do a good job of conducting science consistent with existing academic conventions to reduce bias. So things like open prospective trial registration and transparency in terms of access to the data that we collect. But we certainly haven't separated in terms of ensuring that those who are responsible for recruiting and delivering the intervention aren't actually collecting the outcome data. So those processes are in place, but there isn't a separation, a distinct separation for the purposes of independence of evaluation in at least the model that we've run.
Yes, very different approaches and really interesting. So thanks for those comments. So look, we've just got we've got about 10 minutes left, so I think I might just see whether Davina Guernsey, whether you have any comments or questions that you might like to put. Davina, yeah.
Thanks, Sally. I was just trying to find my unmute button. No, nothing's coming to mind. I've really enjoyed the webinar though, so thank you.
Thanks, Davina. And Andrew, as a sort of a co-convener of this, Andrew Millett, is there anything else that you would like to ask before we?
No, those sort of comments, Sally, but just to say that it's been a fantastic lineup today and different perspectives on an issue which is often vexing for policymakers and practitioners around the role of evaluation and monitoring. And I think it's great to see that there are sort of different approaches, and as you said, Luke's model is a very different one and a very unique one in that it is fully embedded. I would call them sort of researcher practitioner models. Often, you would see that in a more of a clinical setting, where there are fellowships on that basis. But I think what the model that Luke has got in Hunter New England is quite unique, because literally it's doubling the size of the workforce effectively by drawing on both research resources and implementers. And it's a really interesting model, that there may be merits in sort of replicating in other contexts around the world, but particularly around the country as well. And I think what was interesting about Liz's work as well is that, the fact that we are doing evaluations using linked data and using a whole bunch of different researcher relationships, evaluator relationships, but also internal capacity to do a lot of the evaluation. So it seems to be a very interesting mixed model of engagement with the research sector, but also building that internal capacity and the power of administrative data to pull together all of those data sets and use them to as a tool to change practice and implement consistent models of care and monitor that through our performance monitoring systems. So some really interesting examples in the local context.
Yes.
So it's Liz. So Sally, I was just going to jump in because Andrew did ask me a question. I'm not sure if it's a leading one or not, but thank you, Andrew, online about control groups. Listen, it is something, and Andrew knows this well. I'm not wedded to the need for a control group in every single evaluation that we do, particularly when all of our initiatives are implemented at scale, which makes it often very hard to find a control group because all of our ones are statewide. However, having said that, we have done things like in diabetes where we've set up a control group for people with type 2 and heart conditions. So we do use that, but what we also, the way we like to evaluate too is to look at whether we've bent the curve, against a BAU kind of approach if we didn't have the intervention, and that's kind of growing in its sophistication, I suppose. So we tend to have a blended approach, but thank you for that question, Andrew.
Well, it's a sort of an issue, Liz, that we could have a whole session on just in itself. How do you sort of, what is baseline or control? And there's been so many other really interesting issues that have flagged up in the discussion today. I note that. Can you hear me okay? Yeah. I note that at the last discussion online around the role of publications in peer-reviewed journals, which is a really important issue. Somebody mentioned the use of large data and how they might play into evaluation, which is something that at Sax we're particularly interested in. And then I think there's also the whole issue around, so Robin Newson asked a really interesting question, which we haven't really had time to get to, which is about the role of innovation in here and how that plays out as you're thinking about evaluations. And I've always been intrigued that the title of Nick's organisation is Policy Innovation Research Unit. So it focuses on evaluating the things that are new in policy. And so, I think these are all really interesting questions. We don't sadly have time to unpack many of them today. So I guess just before we end, I'd just like to say that we think that this is a really interesting and important theme. And I just wonder if people have ideas they might want to feed into the chat or on the panel about what we might do next after this, if anything. Would people be interested in another session like this in a year's time, where we can hear about how some of these longer term initiatives have perhaps played out, or perhaps with some different case studies? Are there tools or other resources? There's been a lot of interest, Liz, in your database, I notice, online. Is there some value in us hosting a session, a presentation for people who are here today who might like to hear more about it? Or are there other things that we can do? I think one of Nick's responses about publication was about sort of training up the next generation of people who might have the skills and interest and capacity to deliver in that space. So I don't know if anybody wants to make a comment on next steps from here, or add it to the chat line, or contact Amanda Dominello or myself afterwards. But do let us know, because I think these are all the kind of discussion we've had this morning. I think has been very helpful in terms of getting started, but it feels like, sorry, I'm just laughing at Zelda's comment. Yes, please. And Kate's. So it sounds like it would be worthwhile to have some follow-up discussion around this, and we can get together and think about how that might best be framed. But if anybody would like to be involved in helping us with that, please let us know, and we'd love to connect. I'm really aware that there's lots of other people online who also have fascinating case studies and have contributed to the methodological literature and debate. So I'm sorry we couldn't have had more people present today, but do let us know if you would like to draw the attention of a wider audience to the work that you're doing in this space. So again, you can email me directly, or Amanda Dominello. Amanda's probably more reliable, but do feel free to be in contact. So I don't know if anybody has any last comments that they want to make from around the panel, but I might just offer an opportunity. Nick must be ready for cocoa, I would think. Would anybody like to make any last comments as we close quickly?
Well, one thing.
Oh,
sorry.
No, you go, Nick.
And then Liz.
One thing that intrigued me with it was this distinction between evaluation and research, and I suspect it's more to do with the sort of governance arrangements and perhaps what I might call it the sort of bureaucratic definitions. It really worries me, and I regard evaluation as a type of research, and I regard research ethics processes as what they should be is risk-based, irrespective of whether it's audit, evaluation, or research. So I am always discomforted and puzzled when people say, oh, well, that's only evaluation, therefore you don't need research ethics, or we're just doing an audit, therefore, and then the whole kind of research ethics sort of toolkit is hurled at the academics simply because they're doing something called research. So I know that really is a rather strange situation. It seems to me that if you're doing something that is low risk, then you don't, there are various regulatory hoops you shouldn't need to go through, but it's the nature of the activity, not the label attached to it, or where the activity is based. But that's just one of my hobby horses.
Yes, and so Nick, I think might let Liz respond quickly to that, bearing in mind we just have 2 minutes. But actually, before you do, Liz, I would just say that I've noticed sometimes when I'm talking to policy people that research doesn't have the same rosy glow that it has for people who work in universities, and I wonder if that's a part of it. So sometimes there's a closing down when you start to say, well, we could do some research on that. So Liz, over to you.
Okay. So research is a key enabler of value-based healthcare, and we've recently released, and I can send it to maybe Amanda and she can disseminate it, our research kind of policy framework for working on value-based healthcare. So we are really looking to partner. Having said that I think it's fair to say that evaluation has developed into its own kind of field in New South Wales. We have legislation that allows rapid access to data as long as it's not for research, which still must go through the ethics process. And that was because we were really struggling answering questions of government, and our COVID linked public health database is a great example of how that legislation's really worked well for us. And to use that data for evaluation, planning, etc., you do not need ethics. So that stood us in a really good stead. We are looking to partner. Research has a role, but there is, you know, I think that there's intersections and complementaries there, but evaluation is really to try and there's a different purpose as to why we evaluate, as to why we do research. So having said that, I'm an assessor also on our translational research group grant program. We've this is my second year doing it and looking for great alignment, and it's been a great piece of work bringing together that translational research, the evaluation that supports that, and then translating the successful ones across the system. So we are really partnering well with our researchers and working well, but we are seeing that kind of, you know, they intersect, but they're not the same. So I think that would be a really good topic.
Yeah, it sounds like it. And due to poor chairing, I suspect we've got this raised at the dying moments, but there's nothing like a kind of controversy right at the end to open up to further discussion for the future. So I think it is an important issue, Nick, and I'm probably more aligned with you than with Liz, but it would be a really interesting thing to kind of chat through, thinking about different lenses. So there's been a great response on the chat to my question about what we might do in the future. So thanks for all of those suggestions. We will definitely circulate the slides, and we'll also circulate the short summary of the key issues that were raised, including this last controversy. So that should be, we'll look forward to doing that, the slides quickly and the summary a little bit longer. So Amanda's thoughtfully put up how you can contact us on the screen there, and don't hesitate to be in touch with other suggestions. So I'm not sure how we do this online, but I'd like you to just join me in thanking all of our presenters today, who all provided really thoughtful presentations. Oh, look at this. Oh, I've never seen that before. So many hands clapping on the screen. It's just a delight. Thank you. And so thanks so much, all of you. I know it's time consuming to develop a presentation like that, and the shorter they are, in some ways, the harder they are to put together. So thank you so much. Really appreciate it. And we'll be in touch with everybody. So let's finish, and only 2 minutes over, not as bad as it might have been. Thanks so much, everybody. Take care. Bye.
Thanks,